Thank you, Narayan, for this introduction. So I'm presenting this work on behalf of the urology team of the Hospital of Lyon. Thomas Stu couldn't be here today. So I will describe some results we got using HIFU for treating a patient with recurrent prostate cancer after brachytherapy. You probably know what is brachytherapy. It consists in implanting small radioactive seeds in the prostate. For these patients, if we look at the guidelines, international guidelines, recent, it says that the biochemical disease-free survival for this patient is range between 65 and 85% at 10 years. So there is clearly room for improvement. And because unfortunately there is no solution for these patients, in vast majority of cases, the treatment consists in hormone therapy, which is only palliative and associated with severe adverse effect. So the goal of this work is to evaluate how Salvage HIFU can respond to this need for this locally recurrent prostate cancer. We performed a clinical trial between 2003 and 2015 on 50 patients, which were selected. This patient had brachytherapy that failed, and we proposed this Salvage HIFU. We always took patients without metastasis, although you see that this was problematic. In order to do so, since 2012, we use PET, but before that, it was only occasional, depending on the accessibility of the equipment. For the equipment, the period was quite long, so we had two systems. In the early phase, we used the ablatorm, so the system from EDAP for prostate cancer. And after, in the more recent years, we use a focal one, which is the same device, but allowing focal therapy. The acoustical parameters were adjusted. In the early stage, between 2003 and 2007, we used the same parameters which were selected for patients we had HIFU after external beam radiation therapy. And since 2008, these parameters were adjusted in order to take into account that the prostate is a bit different after this brachytherapy. Similarly, over the years, we had different treatment before the whole gland was treated, so before 2009, and since 2009, if possible, we perform only anemia ablation. The primary outcomes of this study are given on this slide. We look at the progression-free survival, which consists in the absence of a biochemical failure, so we don't want the PSA nadir to increase by 2 nanograms per milliliter, and we also consider as a failure if the patient had to receive an adjuvant treatment. Secondary outcomes, we look at the overall survival, the cancer-specific survival, and the metastasis-free survivals, and different undesired side effects like continence, erectile dysfunction, and other complications. So this is how the patients are dispatched around among the groups. So we had 50 patients again. 30 benefited from unilateral treatment and 20 bilateral. Among these 40 patients, 8 had a seminal vesicle invasion. Probably they should not be included in the study, but they were. And this patient had a hormonotherapy, which was stopped before the Salvage HIFU. So back to my parameters. So 13 patients had the parameters from external beam radiation therapy, and 37 had the specific parameters for brachytherapy. 35 have whole gland ablation, and 15 had MB ablation. The follow-up of this patient was performed on a period of 4.5 years, and we got a PSA nadir post-Salvage HIFU of 0.3 nanograms per milliliter. So this is the progression-free survival, which reached 41% at 6 years. Keep in mind that probably we included patients with metastasis by mistake, and this is what you can see in this other survival curve with 75% metastasis-free survival at 7 years. So, well, in this group, 9 patients developed metastasis, and only 2 had a PET, so probably we included too many patients in this group. So if we perform a subgroup analysis looking at the functional outcomes, it's very interesting to see that when we apply our parameters which are specific to brachytherapy, we have much less incontinence. And obviously, if we perform HEMI ablation instead of whole-gland ablation, we have much less side effects like incontinence, bladder outlet obstruction, or complications. Regarding the erectile function, we maintained 50%. It was maintained in 50% at one of the patient at one year for the patient who had erectile function before the treatment. In discussion, I'd like to compare the complications we got depending on the specific parameters. So in order to do so, we consider around 300 patients who had the treatment with parameters for external beam radiation therapy. And we compare with our 37 patients, we had the treatment with the specific parameters for brachytherapy. So it is very important. Well, we have pretty similar rate of complications, but obviously higher for these patients with brachytherapy because the prostate is more fibrous, less vascularized. So it's very important to adjust our parameters. But still, this result demonstrates it's possible to treat this patient with that are recurrent cancer after brachytherapy. So in conclusion, Salvage HIFU for locally recurrent prostate cancer after brachytherapy is challenging but possible. We presented here the largest series of salvage therapy for this indication, and at 7 years, the metastasis-free survival rate is 75%. We worked hard in order to improve the exposure conditions in order to be safer for these patients. And what we advise now is to perform salvage HIFU HEMI ablation, if possible, obviously, to achieve an even more favorable efficacy to CST ratio. And I thank you very much for your attention.
Thank you very much indeed. This paper is open for questions. Beji?
Nice presentation, Cyril. Thank you. How do you decide who gets a HEMI ablation versus a whole gland? Is it based on what you see on MR or based on biopsy? And also, is the progression-free survival the same between the whole gland and the HEMI ablation patients? Obviously, the safety was better, but what about the efficacy?
So I will ask you your first question, and then you will repeat the second question. So the first question, you're right. It's based on the biopsy and MRI, and you know that the focal one has a possibility to import the MRI in the system so you can precisely target what you want to treat. So what's your second question?
The second question was, in the patients that got HEMI ablation, did they have the same efficacy results as the whole gland ablation patients? You showed that it was a safer approach, but what about the efficacy?
Well, I'm not sure because we need a long-term follow-up, and the HEMI ablation is more recent, so I'm not sure I can respond yet on this question.
Thank you.
Other question? Yep.
It's my first time to visit this kind of conference, and I'm very new to HIFU. And I'm a radiation oncologist. What I'm asking is that the complication rate for the after EBMRT is greater than brachytherapy. Why is that happening?
I'm not sure I got the question. The complication rate is higher.
Compared to brachytherapy, EBMRT complication rate is much more. So
let me,
what's the reason?
yeah,
Sure, go ahead.
you are right. We also conducted a study for the recurrent cancer of post-EBRT, and we had quite success in terms of reducing the complications that are encountered during the surgery, for example, rectal or bowel motions, etc. So HIFU does help for those patient population that is a recurrent cancer. Now, the question for you was these seeds. Did you image the seeds before? Were there seeds still in the prostates, or you don't know?
Well, the seeds are still in the prostate, and before this work, there was some clinical trials where we've seen that there is no interference in terms of lesion size when we use HIFU over the seeds. So there's no impact.
And another thing is that, after the recurrence after radiation therapy, can you imagine, or what is the indication of the focal or local therapy after external beam radiation?
Well, that's what Naren responded. I mean, it has been this system, and both EDAP and Sonacare has been using as a salvage solution for a patient who failed after radiotherapy, and the results are quite interesting with less side effect and similar efficacy.
After this session, I will give you the reference for the publications on this particular thing. Okay.
Thank you.
Thank you very much. We must move on.